Hello, so today we will discuss the treatment of pulmonary embolism, and this can be divided then into stable patients and then into unstable patients. Unstable patient means that the blood pressure is less than 90 systolic for more than 15 minutes. That's the definition of unstable patient. So a patient comes with a pulmonary embolism and the patient has a blood pressure of less than 90. Then I group these patients into unstable patients. What do I need to do with unstable patients? I need to make them stable. And how do I make the unstable patient stable? I give them intravenously fluid. So we give fluid. And this fluid have to be around 500 milliliter to 1000 milliliter. 500 to 1000 milliliter. Then I give oxygen because the oxygen level has to be more than 90%. So if I see that the oxygen is less than 90, then I need to give oxygen. So two values, as you can see, is less than 90 blood pressure, so less than 90 systolic blood pressure, and less than 90% oxygen in the blood. How do I know how much the oxygen the patient has in the blood? I just look at the finger with a device which is called pulse oximeter. I put a pulse oximeter in the finger and then I check the oxygen level, and if it's less than 90, then I start to add oxygen to this patient. So here is a patient, here is the nose of the patient. I put oxygen through the nose. I give it 2 liters per minute. If that is not enough, if I see that the percent is not increasing, then I give 4 liters per minute. If that is not enough, then I give 6 liters per minute until I see a better percentage. And if I see that this patient has respiratory failure and I cannot increase the percent with this kind of method, so this is just a tube with oxygen into the nose. If that is not enough, then I need to do an intubation. So here's a mouth. I put a device here, which I open up the mouth. So this is called intubation. And then I put a tube into his lungs. So this is through his mouth, into the mouth, through his trachea, into the lungs. And then I can, with a balloon, ventilate this patient, or with a machine, giving him oxygen with a machine. That's intubation. So if this does not work, it's called intubation. Intubation. Okay? So now I have been giving oxygen, I have been giving fluid, and I see that this alone does not help. The pressure is still 90. So when you give fluid, you increase the volume of the fluid in the blood, and therefore you increase the pressure. But if this does not help, then you need to be give vasopressors. Vasopressors, okay? Vasopressors. And which vasopressor? The most important here is something called norepinephrine. So norepinephrine. Why is norepinephrine better than epinephrine or dopamine? Because these are also two vasopressors. Norepinephrine does not cause tachycardia. So no tachycardia. Tachycardia just means heartbeat more than 100. So norepinephrine does not cause, because if you have tachycardia, then this blood pressure will be worse. So that's not good. We need to increase this. We don't need to decrease it. So if you would give dopamine or epinephrine, these both vasopressors would cause tachycardia, which would worsen this blood pressure. So no, we don't need you. We need norepinephrine. We need norepinephrine as vasopressor. And also we can give dobutamine. Dobutamine. That will increase the heart contractility. Contractility. So contractility means that the heart starts to pump stronger with dobutamine. And you never give dobutamine alone. Why? Because this dobutamine can also cause a vasodilation, which means that you dilate the arteries. That means that the pressure gets less again. So dobutamine has a positive thing that it increases contractility, the muscle strength, but it has also a negative thing that it increases vasodilation, causing that the volume of the artery is larger, which means that the pressure decreases. So dobutamine should be given together with norepinephrine, or you just give norepinephrine alone. But if you see that norepinephrine alone does not work, then you need to add dobutamine. Okay, so to conclude, we have tried to make unstable stable. And what if this does not help? Then we go on with something called thrombolysis. And thrombolysis, the medication that you need to remember is alteplase. Alteplase. And you give 100 milligram in 2 hours. And why is alteplase the better choice? You have urokinase also and streptokinase, but alteplase is better because you can give it in a shorter time. And it has been proven that if you give thrombolysis in a shorter time, that's better, that has less bleeding complications than if you would give streptokinase or urokinase, which you have to give for more than 2 hours. Okay, so alteplase 100 milligram. What if this does not help? So we have been giving intravenous fluid, vasopressors, oxygen. We have been giving thrombolysis for 2 hours and it does not help. Now make another thrombolysis. This is systematically. So you put this medication in the vein and this enters your whole body. What if the second time does not help? Then you need to do something called catheter-directed thrombolysis, which means that you put the same medication, but here you have your heart, you enter a catheter here you have the pulmonary artery, here you have pulmonary artery, and you enter the catheter here, for example, here is the thrombus, and then you come close to the thrombus locally, and then you release the medication at the point, at the spot here. So you don't put medication in your whole body, you put it catheter directed here at the point of the embolus. Okay, then we have tried that. If that does not work, then we need to do surgery. So here we have surgery. And this is called embolectomy, surgical embolectomy. Embolectomy. That is when the surgeon will cut up the thrombus and remove it manually. So, now this was unstable patients. What about stable patients? Stable patients, you just need to remember you do the same thing, intravenous fluid, oxygen and so on, but you give anticoagulants. And then we need to know which type of anticoagulants we have. Or first, I will say what if the patient cannot take anticoagulants. I will do a mark here. Then we need to give inferior Vena Cava filter. Inferior Vena Cava filter. And here we have a heart. Again, here we have the inferior Vena Cava vein that is coming to the heart. And what we will do is, here we have the pulmonary artery. So here is a thrombus in your lower leg. So here is your lower leg. Now let's make it like this. So here is the lower leg. Here we have a vein coming, and here we have a thrombus. A thrombus just means that you have cells that have coagulated and now they stick together and become a ball. They become a thrombus. And now this will move upwards like this, into your heart, into the pulmonary artery, and then it will block the pulmonary artery. And this part of this whole lung will now be embolized, which means that it will not get any oxygen anymore because it's blocked. The artery supply to the lung is blocked. What can we do? We can give anticoagulation, as we said, but if the patient cannot does not tolerate anticoagulants, or if the anticoagulants are causing a lot of bleeding in the patient, because bleeding is a complication of anticoagulants, then what we do an inferior vena cava filter, which means that we put the filter here in this inferior cava vein here. So we block it here. So it means that the thrombus can now only reach until this part. It will never reach the heart and never reach the pulmonary artery. That's very, very good. But now let's talk about patients who can tolerate anticoagulants. So the whole purpose with anticoagulants is that we have a ball of coagulate here, and we want to make it like this. So it's small particles, which means it does not block the artery flow, okay? Because this will block the artery flow. This will not block the artery flow. That's the whole purpose of anticoagulants. And what type do we have? We have heparins. Heparins, and these are called low molecular weight. First of all, we talk about the unfractionated heparin. That's the normal heparin. It's not fractionated, because low molecular weight heparin is fractionated. We have been cutting this normal heparin. So let's say, I will just draw a thing here. Let's say the heparin is looking like this. Heparin, and then low molecular weight is then looking something like this. Okay, we fractionated this part so it looks like this. Okay, it is smaller, and therefore we call it low molecular. There are smaller, lower molecular parts. And why is this have many advantages? So low molecular weight heparin is better than unfractionated heparin in most cases, but in certain cases unfractionated heparin is better. Okay, so this you have to read about it. It's quite complex of which one you choose for which type. For example, low molecular weight heparin. When do we use that? For example, if you have a pregnancy. Here is a little child in the pregnant woman. Then you use low molecular weight heparin. Or if you have a tumor, this is a cancer. So pregnancy, cancer, and in liver diseases. In these cases, you need to choose the low molecular weight heparin. When do we choose the unfractionated heparin? We choose it in kidney disease. So in kidney disease, we choose unfractionated heparin. Good. So these are some examples. Let's continue. So we had low molecular weight heparin, unfractionated heparin. Then we have the direct oral anticoagulants. These are medications that can be taken by a pill. Here, what do we have? We have dabigatran, for example. Dabigatran. Then these are thrombin inhibitors. So I write thrombin inhibitors. Let's do it in that way. Thrombin inhibitors is that's dabigatran. Then you have factor 10A inhibitors. Here we have rivaroxaban. Then you have apixaban. You see, it's ending with xaban, and then you have edoxaban. Xaban. These are the 10A inhibitors, thrombin inhibitors, dabigatran. Good. These all are grouped in, and they are called direct oral anticoagulants. Good. Then you have something called vitamin K anticoagulants. This is the so-called warfarin. And then you have something called fondaparinux. Okay? So, what is the disadvantage of the heparins? There are some, there is a disease that is called HIT. that is heparin-induced thrombocytopenia. Thrombocytopenia just means that the thrombocytes cell count is getting less than it usually. Penia means less. So thrombocytopenia, heparin-induced thrombocytopenia, and that's very, very, very dangerous. So if this patient have these complications by heparins, you are of course not allowed to give these type of medications. Okay, then you need to, for example, give fondaparinux. Okay, and you give low molecular weight heparin by injection. So that's injected into the skin. Okay, the same goes with fondaparinux, also injected into the skin. These are giving orally. You take medication orally by tablets, by these ones. Here, these ones you inject, and that one, unfractionated heparin, you give it intravenously. Unfractionated heparin intravenously, which means that you give it in the vein. Low molecular weight heparin in the skin. Direct or anticoagulated in your mouth. That's the difference, okay? Good. Let's mention two names of low molecular weight heparins. You have enoxaparin, and dalteparin. These are low molecular weight heparins. Good. Which medication does have an antidote? Why is it important to have an antidote? Let's say you give these anticoagulations and then you can get the bleeding because you're anticoagulating. Then we need to give an antidote. What is the antidote? Do we have an antidote for the direct oral anticoagulants for these for rivaroxaban and all these? No, for the oral medications we don't have an antidote. So we only have antidote for this vitamin K antagonist, which was warfarin. And what is the antidote? The antidote is vitamin K. What then we have for low molecular weight heparin? We have an antidote which is protamine sulfate. And then what do we have next? Dabigatran. So, as you see, I said that for the direct oral anticoagulants, we don't have any antidote, but we have it only for dabigatran. Okay, this was one of the. So this statement was not correct. I would say that usually we don't have it for direct oral anticoagulants, except for dabigatran. That's the only thing that has an antidote. And it's kind of funny name. We can divide the name into three parts. Ida, Rucizumab. Ida, Rucizumab. That's the antidote for dabigatran. Low molecular weight heparin has protamine sulfate as an antidote. Vitamin K anticoagulants like warfarin has an antidote of vitamin K. So it means that if you gave warfarin to a patient and you see that that he's bleeding, please give vitamin K. If you give low molecular weight heparin to a patient and you see that he's bleeding, please give protamine sulfate, and so on. For dabigatran, please give idarucizumab. Good. How can you check the level? How can you monitor warfarin? You monitor it with something called INR. So that's in the lab. You check the INR value and then you can see that the level of the anticoagulation and bleeding is in balance. It's not too much, it's not too less. Because if you give too much of this, you get bleeding. If you get too less of it, you get the thrombus. So this is the balance. So if you want, you can have like this. Bleeding is on one side and thrombus is on the other side. And if you get that in balance, you have a good INR. For unfractionated heparin, you check the APTT value. So for warfarin, you check INR. For unfractionated heparin, you check APTT value. For warfarin, the INR should be around 2 to 3 in the lab. For APTT, it should be around 1.5 to 2.5. Okay? So, simple case. Patient comes in, you suspect pulmonary embolism, and the bleeding risk is low in this patient. The pulmonary embolism Wells score, which I discussed in another video, showed that the pulmonary embolism risk is very high. There's a high risk of pulmonary embolism. What do we do then? We anticoagulate. AC is the abbreviation I will use for anticoagulation. We give anticoagulants. If the pulmonary embolism risk is high, but the bleeding risk is low. If the bleeding risk is low and the pulmonary embolism risk is intermediate, then I anticoagulate if the diagnosis will take more than 4 hours to perform. It will take more than 4 hours for us to be sure that this is pulmonary embolism. Then I give anticoagulants. Or if the pulmonary embolism probability is low, that it's kind of low risk that this is pulmonary embolism, then I do anticoagulation only if the diagnosis will take more than 24 hours. So this was when the bleeding is low. What do I do when the bleeding is moderate? Then I only anticoagulate when the probability here is high. Then I do an anticoagulation. As you see, I did it here also. When the probability is high, I give anticoagulation. But when the bleeding was low, I also anticoagulated in intermediate risk, and I also anticoagulated low risk, depending on how long it takes for the diagnosis to take place. But in moderate risk bleeding, I don't care about intermediate or low. I only care about if the probability is high for pulmonary embolism, then I will do anticoagulation. What if the probability is high for a bleeding? So it's two things here, bleeding risk and pulmonary embolism risk. If the risk of bleeding is very high, then I don't do any anticoagulation. I'm not allowed to anticoagulate a patient that have a very high risk of bleeding. Then he will die of that. Which is better, if you die of bleeding or if you die of pulmonary embolism? This is what we talked about. This is the balance. You always need to balance bleeding with thrombus formation. Good. Now that you know this, let's make a quick summary. So, the patient comes in and I see that his is unstable. I measure the blood pressure and I see that it's less than 90. I know that this is unstable. Then I start with intravenous fluid. Then I start with oxygen. If I see that this is not working, then I do vasopressors, and I will write norepinephrine directly here because you know what it is. Norepinephrine. If this does not help, then I do thrombolysis. With what? With alteplase. 100 milligram in 2 hours. If this does not work, then I do a catheter directed thrombolysis. If this does not work, then I do a surgery, embolectomy. Good, that was unstable, then you know it. Stable, I just write anticoagulation. I mentioned many types. I mentioned unfractionated heparin. I mentioned low molecular weight heparin. Please name 2 low molecular weight heparin. Enoxaparin and dalteparin. Okay, good. This is their normal heparin. Then we have the direct oral anticoagulants. We had the dabigatran. Then we had this Xaban, rivaroxaban. Then we had apixaban. Then we have edoxaban. Good, this was the direct oral anticoagulants. Then we have vitamin K antagonist, which is the warfarin. Then we had fondaparinux. When do we give fondaparinux? When we suspect that the heparins will give HIT, which is heparin-induced thrombocytopenia. Then I give fondaparinux. How do I give it? Orally? No. You give it subcutaneously. How do I give this? Subcutaneously. How do I give this? Intravenously. Subcutaneously. So this is skin, intravenous, and this is also skin. How do you give this? Orally. Good. When do we give unfractionated heparin? In kidney disease. When do we give low molecular weight? In pregnancy, in cancer, and in liver disease. Okay. What if the patient cannot tolerate any of these anticoagulants because the bleeding risk is too high? Because we said if the bleeding risk is too high, we don't give anticoagulants. Then we do inferior vena cava filter. Do you remember? Here we have the heart, here we have the inferior cava, and we put a filter here so that the thrombus cannot reach the heart and the pulmonary artery. Good. How do we diagnose the patient quickly? Or what is the most important diagnostic tool that we can use? That's the CT angiopulmonary, CT angio of the pulmonary system. So this is the tube that you enter the patient in. So the patient is lying and then you check the pulmonary system by the CT. That's the most important. If you don't have this in-house, then you have something called portable perfusion scanning. So if you tried out CT, now, if you don't have CT, then you do portable perfusion scanning. If you don't have this, then you do an echo. So cardiac echocardiograph, and you have two types. You have TTE and TEE. That stands for transthoracic echocardiography, which is through the thorax, and this is through the esophagus, transesophageal echocardiogram. Good. So. And what do we see in the echo? This is a heart, 4 parts, right ventricle, and this right ventricle is enlarged. But the apex part is not. So this is not affected. Only this is not functioning. This wall is not functioning in the right ventricle, but apex is functioning. We call this McConnell sign. McConnell sign, and that can be seen in echocardiogram. Good, but you only do this when you didn't have CT of the pulmonary system and you didn't have a portable perfusion scanning. Okay, good. So remember, tumor, low molecular weight heparin. Pregnancy, also low molecular weight heparin. Liver disease, also low molecular weight heparin. So these are special patient groups. And which medications can be given orally? We said the direct oral anticoagulants. 2 medications out of these, which is called rivaroxaban and apixaban. These can be given individually. So monotherapy is called monotherapy. That just means that you can give these 2 medications alone. You don't need to give heparin first, because with the other with the other direct oral anticoagulants, you need to give heparin for 5 days, and then you can give the other one, which was edoxaban and dabigatran. So you see, with these two you can give directly, and that, in that sense, is more convenient. With the other direct oral anticoagulants like edoxaban and dabigatran, you need to give heparin for 5 days. So unfractionated heparin, for example. Good. So the most important this is a very huge topic that I try to simplify as much as possible. The most important thing was unstable or stable. Stable is less than 90 systolic blood pressure for more than 15 minutes. You give intravenous fluid, you give oxygen. If that is not enough, you need to give vasopressors, norepinephrine. If that is not enough, then a catheter, then thrombolysis systemically in the vein. If that is not enough, then you repeat thrombolysis. If that is not enough, then catheter-directed thrombolysis. If that is not enough, then you give surgical embolectomy. That was unstable patient. Stable patients, you do anticoagulants. You give also intravenous fluid and so on, but the most important, anticoagulants. You have more time. How many patients have stable? 9 out of 10 patients have stable, and only 1 out of 10 have unstable. So most of the patients will be in the stable group. What do we do here? We give anticoagulants. Which ones did we have? Unfractionated heparin, low molecular weight heparin. Then we had, what did we have? We had the direct oral anticoagulants like dabigatran, rivaroxaban, edoxaban, apixaban. Okay? Then we had vitamin K antagonists like warfarin. Then we had fondaparinux. Fondaparinux when we are not allowed to use heparins because heparin induced the thrombocytopenia. Okay, so, and then you need to remember which one you are allowed. In pregnancy, you are only allowed to give low molecular weight heparins. In liver diseases, you should also do that. In cancer, you should also do that. If you want a monotherapy of direct oral anticoagulants, you give rivaroxaban and apixaban, because this can be given as monotherapy. What do you do if the patient have a high bleeding risk? You don't give anticoagulants then you do an inferior vena cava filter. So you get the point. Balance, please, the bleeding and the thrombosis.